Thank you, Padre, for this very flattering introduction. I don't know if I deserve 90% of that, but thank you.
Not at all.
So when Badri asked me to do this presentation, I said, it's too big. I cannot talk about diabetes without any specific focus on parts of it. So I thought, since he just mentioned that it's a world issue and that diabetes has become an epidemic all over the world, my thought is that if you understand the pathophysiology just means the altered physiology of diabetes, that it will be easier for everybody to manage diabetes, particularly physicians who take care of diabetes patients. So with that introduction, we know that the treatment of diabetes goes back to 1921 when insulin was first discovered. From then on, there were many, many more anti-diabetic medications that have been discovered and put into practice. The first pills to be discovered was much later, in 1955, when the sulfonylureas, which are oral anti-diabetic medications that stimulate insulin production, were first introduced. 1982 was a landmark year when human insulin was synthesized. Until then, there was this problem that the world was running out of insulin because it was all from animal sources. But when recombinant insulin was synthesized, it changed the whole picture that there was unlimited amounts of insulin. Then came, at least in the United States, biguanides, metformin, which was available even before that in many other countries. That's a second type of oral agent. Then came acarbose, which decreases absorption of glucose from the gut, was also added to the armamentarium. And in 1996, the first insulin analog, that is short-acting insulin, which was very important for type 1 diabetes, which we'll talk about in a second, was introduced. And 97, insulin sensitizers came into picture. And 98, many other oral anti-diabetic insulin stimulators were introduced until 2013, when the most recent addition of SGLT2 inhibitors, which work on the kidney, were introduced. So this gives us a picture that things are evolving, that the story is not yet complete in the evolution of the understanding and thereby the management of diabetes. And Dr. Badri just gave you the statistics on the world population getting more diabetes, so that somewhere in 2035, it's estimated that there'll be like 600 million people around the world with diabetes, and many of them go undiagnosed. So it is a major epidemic and a major financial problem to the world. I'll just mention that there are two main types of diabetes, type 1 and type 2. There are other subtypes which you won't go on into. Basically, type 1 is the simple pancreatic type, insulin deficiency type 1 diabetes, where there's autoimmune destruction of the beta cells, the islets of Langerhans, which are the places where insulin is secreted. So it's very simple. No insulin, diabetes. Type 2 is a little bit more complex. And there's no way of defining type 2 diabetes. If you want to define that, it would be like chronic hyperglycemia resulting from insulin receptor signaling pathway gene mutations, which just tells us that it's a complicated kind of disorder with genetic underpinnings. But for today's discussion, we'll just confine to type 2 diabetes. That's long enough. And for that, we will just confine ourselves to the pathophysiology of type 2 diabetes. Because if you understand how things happen, then you can introduce things that you can combat that with. And mainly because about 85 to 90% of all cases of diabetes belong to the type 2 categories. So when you talk about diabetes, it's usually type 2 diabetes. The two constants in type 2 diabetes are insulin resistance and beta cell failure. And we'll talk about that in a second. There is genetic susceptibility in type 2 diabetes. We know that. It's not a single gene, it's a polygenic problem. But it's aggravated by lifestyle, which is usually sedentary lifestyle, obesity, diet, maybe excess alcohol, and all the things that happen after the genetic susceptibility is in place. But there are two parts to this: insulin resistance and beta cell dysfunction. Insulin resistance is the inability of or the difficulty of insulin to do the same job that it would have done without insulin resistance. In other words, to do the same job of getting glucose into the liver, glucose into the muscle, and glucose into the adipose tissue or fat, you need higher and higher levels of insulin. You start out with insulin resistance in a lower level, and as time goes on, the degree of insulin resistance gets worse and worse. And that is a hallmark of the production or the conundrum of type 2 diabetes. Beta cell dysfunction is also a constant in type 2 diabetes. What is beta cell dysfunction? It is the inability or the reduced ability of the beta cells in the pancreas to secrete insulin. It's not only the quantitative problem with the beta cell in terms of decreased amount of insulin it can secrete, but also a time factor, because just getting enough insulin is not enough. It has to go at the right time in the right place. And the beta cell has the ability, normally in the non-diabetic individual, to immediately produce insulin, even with a small amount of glucose rise. With the type 2 diabetes, even with the insulin resistance in the pre-diabetic state, that response is delayed, so that it takes longer for the beta cell to respond to levels of glucose. And so this combination of insulin resistance and beta cell dysfunction ultimately results in higher blood glucose readings and diabetes. So if you want to put the pictorial representation into this, it gives you an idea of the time sequence of development of diabetes. So on the left side is normal, on the right side is type 2 diabetes, and in between is the IGT, or impaired glucose tolerance, which we can now define as pre-diabetes, if you want to call it that. The top line, the orange line, is insulin resistance. Way in the youth or in the early stages of the development, insulin resistance is normal. So everything is normal. Then insulin resistance starts going up as the person ages. But then if you look at the second line, which is insulin secretion, the yellow line, you find that there is higher levels of insulin secretion. So the beta cell is very efficient. It can make a lot of insulin, and it responds by increasing the insulin. What that does on the next level, the blue line, is that it keeps the blood glucose levels normal. The blue line is the postprandial, which is after eating, and the fasting glucose in the bottom line also remains normal for a long time. But as you can see on the yellow line, insulin secretion is not indefinite. After a while, the beta cell gets exhausted and insulin level peaks, but insulin resistance keeps going up. At that point in time, you find that there is an abnormality in the glucose levels, because the blood sugar, you need at higher levels of insulin to manage the glucose, and that's not available, so blood sugar starts going up. And if you can look down a little bit more carefully on that, the first thing to go up is the postprandial glucose. But we don't measure postprandial glucose normally. I mean, when do you diagnose diabetes? Oh, when the sugar is high, when I'm fasting. But that's a late phenomenon. The postprandial glucose goes up first. Later on, when the insulin level peaks and starts going down, that's when the fasting glucose level goes up. So the take-home message is that the development of type 2 diabetes is a continuum. It starts very early with insulin resistance, compensated by beta cell hyperfunction, that means more insulin coming out, leading to high blood sugars down the line. And when the beta cell fails is when you really get bad high blood glucose levels. And again, the take-home message is that earlier you intervene, if you can intervene, earlier it's better, because by the time it reaches the right side of the curve, it's late, too late. And this again gives you a time sequence. 0 being the onset, because in most cases, diagnosis of diabetes is usually at the fasting glucose level, because you go for a blood test and then they find, oh, your blood sugar is a little high. But if you look behind that, even up to 15 years before that, even longer, you could demonstrate, if you can do the right tests, insulin resistance, along with that hyperinsulinemia, which means too much insulin or high levels of insulin, but normal glucose. Because if you measure the glucose level, you don't find anything there. You have to measure something else, if you can, that is. And then towards the end of that minus 15-year range, you find that abnormalities are showing up, both with fasting glucose later on and postprandial glucose earlier on. And then as time goes on, many years later, you find that insulin response goes down, insulin resistance stays the same, but blood sugars keep rising. So this is the time sequence of type 2 diabetes, which if we understand that and try to intervene early on, there is a good chance that we could postpone, I don't say prevent, but postpone many of these long-term complications that result from high sugar. Now, this is very important because insulin resistance is not just resistance of insulin to increase glucose uptake in the cell. It is also associated with a host of other cardiovascular risk factors. And what are they? Well, one of them is called the Metabolic Syndrome, which is kind of like the catch-all where you have high blood lipid levels. Usually it is high levels of triglycerides, low levels of HDL, which is the good cholesterol, and variable levels of LDL, which is the bad cholesterol. But that's not the only thing with metabolic syndrome. It's also associated with hyperglycemia, as we said, blood sugars going up, also associated with high blood pressure. It's associated with damage to the blood vessels and clotting abnormalities. In other words, fibrinogen levels are high. Fibrinogen is a clotting factor. Fibrinolysis is low. So that means that clots remain there longer. And now there is also this inflammation issue. It's been considered that the development of type 2 diabetes over a period of time may be an inflammatory disease. HSCRP, a C-reactive protein, which is an inflammatory marker that's used by cardiologists all the time to evaluate cardiac risk factors, is high. Generally speaking, it's higher in type 2 diabetes, suggesting that there is inflammation in this thing causing more damage. So the point is that insulin resistance is not just for glucose, it also causes or is associated with other cardiovascular risk factors, which I don't have to tell the medical audience here, can cause all kinds of complications, mainly peripheral vascular disease, cardiovascular disease, cerebrovascular disease, and then a whole host of microvascular disorders, which are the kidney function, liver, the neuropathy, and retinopathy. But just to remember that the majority of mortality cases in type 2 diabetes is from cardiovascular disease, which includes heart disease and cerebrovascular disease, with all the other disorders being a smaller portion. So when you think of type 2 diabetes, it's not just sugar disease, but it's heart disease. Prevention is most important, not for just diabetes complications, but also for cardiovascular complications. Earlier intervention is best. The longer you wait, the more potential for these things to be more severe in the long term. I just want to put this in there to emphasize that there are two kinds of vascular disorders that we see, microvascular and macrovascular. Microvascular just relates to retinopathy, nephropathy, which is the kidneys, and neuropathy, which is irritation of the nerves with ischemia. Macrovascular complications are the ones we just mentioned, which is heart disease and cerebrovascular disease, which is stroke, and peripheral vascular disease, which is what happens when circulation to the lower extremities is compromised and ultimately can result in gangrene and amputations and all that. So the point with this slide is that even in the state of pre-diabetes, some of these complications can start. So even before the diagnosis of diabetes, there are many cardiovascular issues that go on, which is part of this metabolic syndrome we talked about. Whereas microvascular disease, which is retinopathy, nephropathy, and neuropathy, usually wait until blood sugar levels go up. At any rate, earlier onset, earlier intervention can help prevent later complications. But Diabetes is really a multi-organ disorder, and that's where I'd like to spend some time discussing the pathophysiology of type 2 diabetes. The pancreas, obviously, is the main player in this because that's where insulin is produced. And insulin is the key hormone that controls glucose uptake into the cell. And glucose, as you know, is the main metabolic fuel for the body. So if glucose does not go into the cell, obviously, it goes up in the blood and the cell suffers from lack of energy. And that is, of course, the whole picture of diabetes mellitus. But how does that happen and how does that cause hyperglycemia is the question. And Ralph DeFranzo from San Antonio has been working on this for decades. And he has got a lot of information that put together into what he calls, first he called the triumvirate, and now the ominous octet. And I'll go over that in a few minutes. So this is the first concept of diabetes, type 2 diabetes. There are three organs here. Insulin is made by the pancreas. The liver is a big storage organ of glucose. And insulin facilitates the uptake of glucose into the liver. And insulin keeps that glucose in the form of glycogen, which is storage form of glucose, until it's needed. On the other end, there's a skeletal muscle. Why do we need all this glucose? For energy, which is the main energy part, which is the muscle. So glucose is also taken up by the muscle and stored as muscle glycogen. So these three players were thought to be the triumvirate that caused hyperglycemia if there is dysfunction in one or the other. And that was a very simplistic understanding of type 2 diabetes, and it was very appropriate for that time. Then came more understanding about hyperglycemia and the complicated relationship between several organs in the body. So let's go one step at a time to understand this. Why is it important? Because today we have methods of addressing all of these. Initially, all he had was insulin. So diabetes gave more insulin. And that took care of part of the problem. And at least in the type 1 diabetes patient who had no insulin at all, it prevented death. But in the type 2 diabetic patient, it didn't do much because they already had enough insulin. Some people had more insulin than necessary. And all it did was try to overcome that insulin resistance and pump more insulin into the system. But now we understand that there are several organ systems that play a part. It's like a concert, like a symphony that then causes this conundrum of type 2 diabetes. So let's take it one step at a time because it's important to understand this, because when you treat patients, you have to address all of these different abnormalities or dysfunctions that go on. So let's take the islet cell. The pancreas is the main organ that produces insulin. We know that. Insulin is produced by the beta cell. Beta cells are present in the pancreas. And when there's impaired insulin secretion, high blood sugar. You already know that. The pancreas also has a very important another cell called the alpha cell, which is the anti-insulin hormone, glucagon. Glucagon is produced by the alpha cell, and if you don't have enough glucagon, then there is no way of raising the blood glucose when you suddenly need it. So the alpha cell and the beta cell work in concert. When the blood sugar goes up, the beta cell makes more insulin. When the blood sugar goes down, the alpha cell makes glucagon that immediately tells, stop making insulin and let's make some more sugar. And this delicate balance is important for life because of all the hormones you have. I mean, you could survive weeks together without thyroid hormone. You could survive without cortisone unless you have an acute illness or something. But you cannot survive for more than a few minutes if blood sugar is going to zero. So it's the most important hormone for life. And glucagon and insulin are closely related to that. And the pancreas is the seat of that. In addition to glucagon, it also makes another hormone called amylin. Amylin and insulin are secreted molecule by molecule equal to each other from the beta cell. And amylin, interestingly, has had some other effects, which also are important for life. And we'll talk about that a little later. So that's the pancreas. The next important organ controlling blood sugar, as we said, was the liver. The liver is the storage form of glucose in the form of glycogen, and the liver is highly sensitive to insulin. So if you look at the anatomy, after digestion from the gut, where does the blood go? It goes into the portal circulation, the portal vein. Where does the portal vein go? It goes straight into the liver. So before the blood leaves the gut to go into the general circulation, it has to pass through the liver. And that's where glucose storage happens. So most of the blood that goes to the sugar that goes into the liver is immediately converted to glycogen and stored. And it is released instantaneously if there is a drop in blood sugar. So there's always an unlimited, not unlimited, but a large portion of glucose stored in the liver. Insulin resistance causes a problem there. In insulin resistance, the level of glycogen goes down. At the same time, there is a thing called increased hepatic glucose production, called hepatic glucose output. That goes up. Insulin keeps the liver from over-secreting when there's a lot of sugar in the blood. But if there's resistance, it doesn't do that. So more blood sugar comes out. So that's the second organ. How about the third one? The third one is the skeletal muscle. The skeletal muscle is also a large storage part of glucose in the form of muscle glycogen, also stored so that there will be an immediate release of that into the muscle cell when there is a need for energy use. But insulin resistance goes there also. When there is insulin resistance, glucose uptake into the muscle is decreased, and therefore more glucose goes into the blood, causing high blood sugar or hyperglycemia. So there are four organs already: the beta cell, the alpha cell in the pancreas, the liver, and the muscle. Let's go to the next organ, and the next organ is the fat. Glucose and free fatty acids are absorbed from digestion of food in the gut, and at least the free fatty acids go into the fat cells. And to get that in there, also you need insulin. If there is insulin resistance, there is lipolysis, more fat being lysed into free fatty acids, and that has deleterious effect on the rest of the body. Increased levels of free fatty acids cause insulin resistance or worsens insulin resistance, and thereby increasing glucose levels. So there are now several organs already involved in the management or the control of glucose. From there, let's go to the next organ, which is the gut. The gut, obviously, is somewhere where the food goes into the stomach, it's churned up, and then sent into the small gut to be absorbed of all the digested food materials. However, the stomach and the gut play a very important role hormonally in control of glucose. The stomach's job is not just to hold the food and then push it into the duodenum and into the gut. It's also important for decreasing the rate of expulsion of food into the gut. In type 2 diabetes, this is also altered. So there is rapid gastric emptying. It's a neurologic phenomenon that type 2 diabetes patients have, where food is pushed into the gut too fast, which means that more glucose gets into the small intestine, more absorption of glucose. The other part of the small gut is another important hormone producer. There is an incretin effect which has been discovered in the small gut. Incretins are hormones that have very important effects. GLP-1 or glucagon-like peptide 1 is the most important of the incretins. And what does it do? Incretins have the effect of stimulating beta cells to make more insulin. As soon as food comes into the gut and sugar is being absorbed, immediately it sends a message to the pancreatic beta cell. Hey, here is more glucose coming, make more insulin. And that's what GLP-1, which is the incretin, does. It also has an effect on the alpha cell. It also sends a message to the alpha cell in the pancreas, the one that makes glucagon, the anti-insulin hormone, telling it to stop making glucagon because you don't want more glucose to be coming out of the liver, for example. And thereby it also sends a message to the liver telling it to shut off the hepatic glucose production. So when there's more glucose being absorbed from the gut, incretins, which is GLP-1, tells the organs that make more glucose not to make more glucose. So the blood sugar remains normal. In type 2 diabetes, what happens is that levels of incretin are low, and therefore that effect is also affected. There's another important effect that the incretins or the GLP-1 does, and that is it affects the brain. It tells the brain to stop eating. I mean, how does one know when to stop eating? Because you're hungry, you eat, but then you stop eating. And one of the ways they stop eating by the incretin is by the effects of GLP-1 on the central nervous system. The hypothalamus, which is the seat of satiety, it tells it to stop eating. So these are very important normal functions of the gut, which are altered during type 2 diabetes. So we talked about the beta cell and the alpha cell in the pancreas. We talked about the liver. We talked about the muscle. We talked about the gut and the fat. Now let's take another very important organ that controls blood sugar, and that is the kidneys. The kidneys, as we all know, is a filter. It filters blood of all the waste products. But how does it do that? Well, when blood flows through the glomerulus, which is the filtering part of the kidney, everything except solids pass into the lumen of the glomerulus. White cells, red cells, proteins, they're kept behind. The only thing that passes are the solutes, the dissolved products like sodium, potassium, calcium, magnesium, and all that, and also glucose. But then the tubules through which this filtrate passes are so efficient that all of these electrolytes are reabsorbed, all of the glucose reabsorbed, and only the waste products, which is blood urea nitrogen and creatinine and other products, are excreted in a very important way the kidney functions. The kidney's ability to reabsorb glucose is good, but not unlimited. So that when the blood glucose goes up, the kidney starts telling, I want to get more absorbed into the blood because you don't want to lose sugar. The hormone that the enzyme that does that, the hormone that does that is called SGLT, sodium glucose cotransporter. That's the one that causes the glucose to be reabsorbed. And interestingly, in type 2 diabetes, those levels are increased. So therefore, more glucose is being absorbed back into the circulation. So when the blood sugar goes up, normally after a certain level, I'd say 180 milligrams, I'm sorry, I have to say it in milligrams, less absorption happens and more glucose is excreted in the urine. So one would think in the past that, urine sugar is bad because it tells you you have diabetes. But actually it's a defense mechanism, because if that didn't exist, the organism would die from the other extreme, high sugar. If there is, no urinary glucose excreted in the untreated diabetic patient, within a short time, they could get glucose levels of 1,000 or more. So it's a defense mechanism. But again, it's something that we know is affected by type 2 diabetes in that the blood, the renal threshold for reabsorption of glucose goes higher and higher, causing high blood sugars. The reason for mentioning this is because now we have the agent that will address that particular abnormality and reverse it so that more glucose is being excreted in the urine with that medication rather than being reabsorbed. So that's another thing to think about. And the eighth part, there are 7 already, we talked about the octet. The eighth part is the brain itself. It's not very well understood how the brain really regulates glucose, but it does. In animal experiments, they have proved that time and time again that stimulating certain parts of the brain improves glucose control, whereas stimulating other parts decreases the glucose control. It is in the hypothalamus that we have the satiety center, the one that says, oh, I've eaten enough. And that we think is altered in type 2 diabetes. So all of these organ systems put together plays a part, a concept in the concept of type 2 diabetes and hyperglycemia. So just to put that in perspective, we go again, say pancreas, the gut, the muscle, everything. Impaired glucose secretion in the pancreas causes excess glucagon secretion, impaired amylin secretion that causes elevated blood sugar. In the gut, we talked about rapid stomach emptying causes postprandial rise in blood sugar, impaired incretin secretion in the gut, the GLP-1 secretion causes high blood glucose by all the mechanisms we talked about. Insulin resistance in the muscle causes decreased glucose uptake and thereby again hyperglycemia. Insulin resistance at the adipose tissue level causes all those bad things to happen like TNF-alpha, IL-6, free fatty acids. These are all toxic to the organism. Adiponectin is one of those good hormones that goes down in insulin resistance. Hepatic glucose output is very important to be controlled to prevent hyperglycemia, and insulin resistance causes delay in that and therefore more glucose coming out of the liver. Brain, we talked about satiety and decreased caloric intake, and in the kidney, increasing renal threshold. So having said all these things, the reason why I put that as the topic of conversation today is that now we have agents to address all of these abnormalities, all of these, so that the management of diabetes can take on a multifaceted form. And this slide kind of summarizes all that. Again, going from the pancreas on the left side, impaired glucose secretion can be now addressed with the insulin secretagogues like sulfonylureas and meglitinide, the GLP-1 receptor agonists like the ones, the incretins we talked about, DPP-4 inhibitors. I'm not going to name any of those specifics because there are so many of them. Increased glucagon secretion also is suppressed by the GLP-1 receptor agonists and amylin and DPP-4 inhibitors. Increased hepatic glucose production. Metformin is one of the major agents that decreases that. Thiazolidinediones like rosiglitazone and pioglitazone decrease hepatic glucose output, and insulin also can suppress that. For the gut, we know that metformin helps there. Alpha glucosidase inhibitors, which decrease glucose absorption from the gut, and some bile acid binding resins also help decrease glucose absorption. There is also metformin and insulin and thiazolidinediones acting on the muscle to improve glucose uptake. And in the fat cell, the insulin sensitizer thiazolidinediones help. And the neuromuscular function in the brain, also I told you there are agents that suppress the appetite center so that the organism doesn't eat too much. And bromocriptine, interestingly, it's a dopamine agonist, has also been found to have positive effects upon blood sugar control. And last but not least, the kidney, which we talked about, the SGLT2 inhibitors, the enzyme that reabsorbs blood sugar too much or the glucose from the kidneys, that is overexpressed in type 2 diabetes, and there are medications that will suppress that. So it's a concept. We have all of these organs affecting blood sugar control in diabetes. Interestingly, we have medication that will address all of these things. So what does that mean? It means that in summary, the type 2 diabetes is manifested by a multi-system dysfunction. Understanding that many organs take part in this provides a direction for therapeutic intervention in which we can specify organ dysfunctions. And this can bring about better long-term control of blood sugar and reduce the diabetes complications. This also permits combination of treatments. You know, in the old school of managing diabetes, you'd say start with one pill, go to 2 pills, maybe 3 pills, maybe add insulin, which may be okay. But if you know already that there are these other organ dysfunctions, then you can address all of those with proper combination therapies early on, and thereby not only decrease glucose levels and the complications from hyperglycemia, but also address the cardiovascular and other chronic organ dysfunction we talked about. And most importantly, you could individualize. Now, that's a new term in terms of treatment for any disorder. Try to individualize it to that particular individual. And if you know that these are the things that are going wrong. You could individualize that for that person. And so it is important to know the pathophysiology of type 2 diabetes, and this will help with overall control. Since Heraclitus, the old Greek philosopher, said change is the only constant in life, we are experiencing that in the management of type 2 diabetes because it is changing. And this information I gave you will be obsolete maybe in the next 5 years because we know that there are more research being done into management of type 2 diabetes because the research is towards understanding the pathophysiology of diabetes. And then that can be applied to. So with that, I will stop. And thank you for listening.